X acceleration, however, is not handled as well by the body and results in what is known as shear forces. Even moderate shear forces can result in injury. Some scientists noticed upon examining occupant test data that the peak X acceleration happened to occur at nearly the exact same moment as the peak Z acceleration. This is another graph from the same occupant test data we saw earlier. This was a crash test conducted at just 5 miles per hour. As we can see here, the peak axial acceleration or compressive force reaches about 15 Gs of acceleration, while the peak X acceleration or shear force reaches about 9 Gs at nearly the same moment. These scientists decided to investigate what effect this combined compression and shear had on the spine. But instead of simply observing the external motions of the occupant, they decided to measure what happened to the individual joints of the neck. To study this, a group of Japanese researchers subjected some test subjects to a low-speed whiplash impact, but photographed these tests using cineoradiography, a technique that makes an X-ray movie at very high speeds. This technology allowed the scientists to observe the motion of each vertebrae in the spine in slow motion. What they found was that rear-end collisions resulted in spinal motion that was far more complicated than the normal movement of the spine, and that this abnormal motion could account for the chronic pain seen in some low-speed whiplash patients. To understand how injury can occur in low-speed collisions, we first need to understand normal spinal motion. This is video fluoroscopy footage that shows the normal motion of the neck. As we see during normal flexion and extension, each vertebra contributes to the overall movement of the neck, resulting in a smooth, regular curving of the spine. This smooth motion of the spine is made possible by the facet joints on each individual vertebra. As you can see, the facet joints are angled backwards. During normal spinal movement, these facets glide across one another, allowing the spine a wide range of motion backwards and forwards. Up until 1996, researchers assumed that the spine moved the same way during a rear-end collision as it did in everyday activities. This simple whiplash motion was seen as normal position before the impact, extension backwards, rebound motion forwards, and then back to normal. The newer research, however, showed a completely different motion. First, the head and neck start in the normal position. As we saw earlier in our description of the occupant motion during a collision, the occupant's torso is moved forward first while the head stays in place because of inertia. This difference in the motion between the torso and the head results in a very rapid straightening of the cervical spine. As the torso continues to move forward, the head's inertia keeps it level and fixed in space. This results in a slight degree of flexion in the upper spine, with dramatic extension focused on just a few intervertebral joints in the lower spine. The researchers found that the spine formed an abnormal S-shaped curve at this point during the whiplash impact. Then, as the torso continues to move forward, the head finally extends backwards, resulting in normal extension of the spine. The head then begins to rebound forward. Now, let's compare the two motions of the spine. First, the normal extension. Now, the abnormal S-shaped curve. Ono and his colleagues then analyzed the data that they'd collected from their live occupant, low-speed test collisions. They found that the combination of compressive force and shear force altered the way that the vertebra moved in relation to one another. They first started with established knowledge of how the cervical vertebra move. Previous research had shown that each vertebra rotates around the one below, like this. This point of rotation is referred to in the biomechanical literature as the instantaneous axis of rotation, or IAR, and permits the smooth gliding motion of the facet joints. Ono et al. Then compared this normal rotation with the motion they observed during rear-end impacts and found that the point of rotation, or the IAR, actually moved during a crash. Instead of this motion, they found this motion. These findings prompted Ono and his colleagues to write, "This is a non-physiological motion of the vertebral segments." In summary, they saw that the spine was subjected to rapid compression, then shear, which caused abnormal motion in the facet joint, all from a collision of just 5 miles per hour. Shortly after this research was published, Other research teams from the Yale School of Medicine and Wayne State University reported similar findings. A study conducted by Grauer et al. Was studying the problem of spinal motion at the same time. They examined the degree of rotation between each of the different vertebrae in the spine in a set of simulated car crashes in cadavers. They first measured the normal range of motion that each joint could handle, and then subjected the specimens to impacts of 2.5, 4.5, 6.5, and 8.5 Gs, similar to what an occupant would experience in a low-speed crash. Grauer found that the joints at C3, C4, C6, C7, and C7T1 moved less than 5 degrees during normal extension. When the spine was subjected to greater impacts, the C6, C7, and C7T1 joints experienced dramatically greater rotations than they could handle, while the C3, C4 joint stayed within its physiological range. Another team of researchers from Wayne State University was also studying the problem and performed some different experiments with cadaver spines. They found that the cervical spine does not handle the combination of compression and shear well at all. In fact, they found that the ligaments that hold the spine together weaken dramatically when compressed. As this graph shows, they found that the lower spine lost as much as 70% of its resistance to shear when it was compressed just 40 pounds. 40 pounds of force may seem extreme, but the study by Ono et al. Reported compression of 56 pounds in a collision of just 5 miles per hour. The final piece of the puzzle was discovered by another team of researchers who published their findings in 1999. These scientists decided to study in detail the motions of the facet joints during a rear-end collision. They carefully prepared a cadaver spine with special reflectors placed on each cervical facet joint. They then subjected the spine to an impact approximately equal to a collision of about 4.4 Gs, or what would be experienced during a low-speed crash, and recorded the motion with high-speed video. They found that the facet did indeed experience the abnormal motion that was seen by the other researchers. Instead of gliding smoothly across each other, as facets do in normal motion, the upper facet joint rotated abnormally and pinched the lower joint. Furthermore, these researchers found excessive flexion in the upper spine during the S-shaped portion of the whiplash motion. The authors of this study concluded, excessive stretching of the posterior upper cervical complex and the pinching mechanism due to compression and sliding of the facet joint may explain the presence of suboccipital headache and neck pain, respectively, in patients with whiplash-associated disorders. As we've seen in the last few years, a great deal of high-quality research has pointed to the cervical facet joints as a possible source of whiplash pain from low-speed collisions. One question remains. Do these engineering findings correlate with what physicians find in patients suffering from pain caused by rear-end collisions? The simple answer is yes. A great deal of research on the problem of whiplash has been conducted by a group of researchers at the University of Newcastle in Australia. As early as 1988, this group of scientists had begun to look at the facet joints as a source of chronic symptoms. Then in 1996, they reported in the journal Spine their results from an important study conducted on 52 patients with chronic whiplash pain. The researchers gave the patients either an anesthetic nerve block or a placebo to see if the cervical facet joints were actually involved in the chronic pain. They concluded that of these patients, the prevalence of cervical zygapophyseal joint pain was 60%. They found that the most common places for the facets to be injured were the same places where the spine undergoes abnormal stress, C2, C3, and C5, C6. In 1996, research from Japan was published that added weight to this line of study. These scientists examined the pattern of referred pain from the cervical facet joints by injecting each joint and mapping the pattern of pain that was reported. They created this distribution of pain from the various facet joints. As we can see, the facet joints refer pain in very similar patterns to what is seen in whiplash patients. In 1997, the Australian researchers published some of the most dramatic evidence that whiplash pain is related to injury to the cervical facet joints. In this study, Wallace et al. Decided to study the effectiveness of radiofrequency neurotomy, a surgical procedure that literally cooks the nerves that innervate the facet joints. 17 patients with long-term chronic whiplash pain were randomly given either the real surgical treatment or a sham treatment. 9 patients received the real treatment and 8 received the placebo treatment. The patients were then evaluated 3 months later. Wallace et al. Found that 67% of the patients who received the actual treatment reported complete pain relief. Only 38% of the patients who received the placebo treatment reported complete pain relief. Clearly, the real treatment seemed to relieve the symptoms at a much greater rate than the placebo. But the most remarkable finding was this. In every single one of the patients who reported complete pain relief from the real treatment, there was also a complete and immediate disappearance of the psychological symptoms that these patients had been reporting. The authors of this study wrote, "Somatization, obsessive-compulsive behavior, and depression can readily be seen as rational psychological responses to persisting pain that medical practitioners have not been able to diagnose and treat, and which has been attributed to malingering. These rational responses should disappear if the underlying pain is successfully treated. This is what occurred in the present study." So not only did this study show that the facet joints play a strong role in the issue of chronic whiplash pain, but it also demonstrated that the psychological distress that so often accompanies whiplash is a result of chronic pain, not the other way around. When we look at all the engineering and medical literature that has studied the issue of facet mechanics and symptoms, we see that there is strong evidence that facet joint injury causes pain after rear-end collisions. Some new research, however, shows that there may be other injury mechanisms from low-speed crashes. Some recent studies have focused on the issues of muscle injury and spinal nerve damage. Muscle pain is an extremely common symptom after rear-end collisions, especially in the acute phase of the injury. In 1995, a study by McConnell reported that tenderness of the anterior neck muscles was one of the most common symptoms reported by their crash test volunteers. In fact, high-speed footage of these same tests showed that the test subjects' neck muscles bulged visibly during the early phases of the crash. New research by Sigmund shows that the muscles in the neck may tighten during the early part of the collision as the head begins to extend backwards. Not only may this result in a strain of the neck muscles, but it also seems to increase dramatically the amount of compression that the cervical spine experiences. As we saw earlier, this compression plays a huge role in the mechanism of injury from low-speed crashes. In short, this neck muscle reflex that is designed to protect the body actually may result in greater risk of injury. In 1986, Aldman wrote that rapid extension and flexion, like that seen in low-speed rear-end collisions, might result in rapid pressure changes in the spinal canal. This was studied by Onkren in 1996, who subjected pigs to whiplash trauma. The study discovered that there were dramatic pressure changes in the spinal canal, just as Aldman had predicted. These results were duplicated by Swedish researchers in 1999. Obviously, it is impossible to measure spinal canal pressure changes in living human occupants, but a team of Austrian scientists conducted the same type of study with human cadavers by subjecting the specimens to whiplash motion. They found that the human spine also showed dramatic pressure changes during whiplash motions, and that this pressure pulse occurred at the same time that the rapid S-shaped curve is forming in the spine. The question is, can this rapid change in pressure cause injury? Svensson et al. Was able to study this to some degree by examining the nerve tissue from the swine they used in their study. They found that while the cervical vertebral joints themselves showed no signs of injury, the ganglion of the spinal nerves shown here displayed evidence of nerve cell membrane damage. These indications of damage were most prominent in the area of C6, C8. As we saw earlier, this is the same area of the spine that is subjected to abnormal rotation. The authors of this study hypothesized that the rapid pressure changes in the spinal canal can create a great deal of strain on the spinal nerve roots, which in turn could result in pain symptoms after a low-speed crash. There are literally dozens of factors that can increase the risk of injury from a low-speed car crash. A few of these include head restraint positioning, occupant gender, occupant position, and occupant awareness of the impact. Head restraints are probably the easiest way to prevent injuries from rear-end car crashes. Unfortunately, many people are injured each year because of an inadequate or improperly adjusted head restraint. In 1997, the Insurance Institute for Highway Safety studied 200 different new vehicles and reported that only 3%